Hi everyone, in this video I'm going to cover Chapter 9, Joint.
When we're looking at our joints, the correct term for this is articulations, or where two bones articulate together. Some of the functions that joints provide for us, one is going to be the mobility, right? This is how we are able to move our body. And we'll talk about the differences of these joints and how much they can move. The other thing is that joints are going to be what actually holds everything together. When we are studying joints, we can classify them one of two ways. We can either classify them based on their structure, or we can classify them based on their function or how they're functioning, or how much movement we really have in them. So here on the right, you can see the classification chart. So on one side, we have the functional category. On the other side, we're going to have the structural category. So when we're talking about functional, there are three main joints that we have. There are going to be immovable joints, and you could see the four that fall, or three main categories structurally that fall under this. Then below that, we have amphiarthrotic or amphiarthroses, and these are our slightly movable joints. I think of this like amphibious creature, right? Amphibious creature is both part water, part land. Amphiarthrotic are slightly movable. They sort of move and they sort of don't. Under this, we have two different structural categories that we'll look at. And then we have diarthrotic joints or diarthroses. And these are going to be what we call freely movable joints. And when you think about joints, you probably are thinking about these joints. So these are our synovial type joints. These are what we have in our elbow and our knee and in our hip. So we're going to look at these different joints that we have, but we are going to study all the joints based on their structure, but we'll talk about what functional category they fall in. So we have our fibrous joints, our cartilaginous, and our synovial type joints that we have. Fibrous are going to be joints that are going to be adjacent to each other, that are connected together by fibrous tissue. Cartilaginous joints are going to be united by cartilage, and then synovial joints are going to have that synovial fluid inside of them. So the first one here is our fibrous joints. These are going to be rigid, non-movable type joints. So if we look back at the chart, these are going to be our synarthrotic type joints. So sutures fall under this category. And sutures we find up inside of the skull. And you've probably already looked at the axial skeleton prior to going through this chapter. And in the skull, we have different plates. And those plates are fused together after we're infants, fuse completely together, and these are what we call fibrous type joints. And so these are immovable. Now, before we hit a certain age after birth, these are unfused, and this is going to allow the skull to give room for the brain to develop. And so these are movable. In fact, they aren't completely together, and there are going to be gaps in those. And you looked at those inside of the previous chapter when you looked at fontanelles, and those are going to be the soft spots that we see inside of the skull of infants. And this again is just allowing for movement. But after they fuse together, they are interlocking and non-movable. And they're going to have short connective tissue fibers between the suture type joints. So about middle age, they start to ossify and fuse. And they are called synostoses when they are fully fused. The next syndesmotic joint is going to be a fibrous joint. Now, these are also non-movable, but they are going to be connected by a fiber in between. And we have a couple of places inside of the body that we see this, and this is what we call interosseous membranes. And so this fibrous tissue, here you could see the antibrachial one, and this is between the radius and the ulna. Now, we also have this in the tibia and the fibula. These fibrous joints are going to, one, hold these bones together. Now, there's not a ton of movement, though twisting does happen in the radius and ulna because of the function of the radial head, giving us the different motions that we get inside of our hand of supination and pronation. Now, this interosseous membrane is important because muscles can attach here. Also, nerve supply and blood supply can travel in between openings of this area. So this is, again, the antibrachial fossa that you're seeing here. The next joint that is going to be non-movable is going to be a gomphosis. And this sounds like gums, so it's easy to memorize that we find these in places like our alveolar sockets, or where our teeth go into the socket of our lower and upper jaw. This is a peg and socket type joint, and you could see that there is going to be connective tissue, and this is going to be what we call the periodontal ligaments. And you can see kind of surrounding the root of the tooth, and it's inside the socket, and this is considered a symphysis. Then we get into synchondroses, and this is another synchondrotic joint, so a non-movable joint. So again, there were three of those when we look back at that chart. So this is the third one, and this is a cartilaginous type joint where cartilage is joining together two bones and uniting, making a non-movable type joint. The best example of this is going to be the temporary epiphyseal plates. Remember when we talked about bone growth in long joints, we talked about the epiphyseal line, and that is going to be where hyaline cartilage sits temporarily in infants and children before we hit puberty, and that closes after puberty. But where that line is at is where we are building and ossifying new bone. But while there is that temporary epiphyseal plate where that hyaline cartilage is, that is a good example of a synchondrosis of a cartilaginous joint, so along that area. Another area is the first rib where it attaches to the manubrium, and the cartilage that sits there would also be a synchondrosis. The next one, as far as cartilaginous joints, a symphysis is our example here, and this is where fibrocartilage is present. And a good example would be the pubic symphysis. So when you are looking at the pelvic bone at the very anterior area where the symphysis part of the pubic bone comes together, right and left, is joined together by cartilage. And that cartilage is hyaline cartilage here, type of fibrocartilage. So this is going to be strong but flexible amphiarthrotic type joint. All right, that brings us to synovial joints, which is sort of the majority of the joints inside of our body that move, that we think of like joints. And so there are 6 features that all synovial joints have. So these defining features are found in every single one of them. One is that there is going to be articulating cartilage. Now, articulating cartilage means that you are going to find cartilage on the points of articulation. Articulation is simply where the bones are going to come together and move. And so this hyaline cartilage is going to be important because it sort of acts as a cushion and is going to absorb shock on the ends of the bones. So that way we aren't bone on bone. So kind of adding an extra layer of protection with this cartilage. The next thing is that there is going to be a synovial cavity. So in all our synovial joints, we have these cavities, and they're small little spaces that have fluid sitting inside of it, or synovial fluid sitting inside of that joint cavity. And so you could see that kind of pictured here in this yellow between these two arbitrary bones. You see this synovial fluid, or this gap inside of this area. The other thing is that there is going to be the articular capsule, or the joint, and there's going to be a fibrous layer and a synovial membrane layer. You could see the synovial membrane here and the articulating capsule that's encapsulating the outside of the joint. This is adding for extra stability and also protection within the joint. Synovial fluid, we talked about that. So there's the cavity and the fluid. The 5th feature is that there is reinforcing ligaments. There is going to be capsular type ligaments that are on the fibrous outer layer of the joint. There will be extracapsular capsular, which will be on the outside of the capsule, and intercapsular, which is going to be deep, covered by that synovial membrane. Now, these ligaments, the location of them and the amount of them is going to determine, along with the musculature, how stable any given joint is. That with the articulating surface and how much articulating surface, these are all parts of sort of an equation of either how much movement a joint has or how stable a joint is. When you think about stability versus movement, think about the shoulder versus the hip. Now, the shoulder, we have a wider range of motion that it can go through as opposed to the hip, but often we see dislocations up in the shoulder because there's less stability there. And that is because the actual formation of the socket of that joint. So when we look at the glenoid fossa and the humeral head and its attachment, the articulation is much smaller than what we see in the acetabulum down inside the hip, where the head of the femur is going to articulate. But because there's less articulation in the shoulder, we get a wider range of motion, which is why things like muscular tone is going to play an important role in how well protected any given joint is. So the last and final characteristic of a synovial joint is going to be that it has blood supply and nerve supply. Now, the nerve fibers are going to help with muscle contraction. It's going to monitor joint position. So some of our sensory or peripheral sensory receptors will sit inside of the joint. This is going to tell us information, our brain information about the positioning of the joint, the stretch of the muscles, and also pick up any pain inside of the area. The other thing that's important is that blood supply. Anytime we have blood supply, it is delivering nutrients that we need for repair and for function, including the delivery of oxygen so that we can make ATP and actually make movement happen at those joints. So articular cartilage, synovial cavity, the articular joint capsule, synovial fluid, the reinforcing ligaments, and the nerve and blood supply. So all of these characteristics are what synovial joints are going to have, and the other joints aren't going to have all of these features. Some other things that are associated with our synovial joints, one is going to be the bursa, and bursa are going to be sacs of synovial lined with synovial membrane, and it's going to have synovial fluid in it. And so we can see little sacs of bursa here. And we often see bursa anywhere we need protection or we're going to see movement happening. And it sort of acts like a little pillow with fluid to help reduce any friction. So whether we're talking about muscles or tendons or where bones or even skin is going to rub over structures that lie below it, we're going to see little pockets of bursa. And they're just tiny little, basically water balloons that are helping sort of ease the friction between two of these adjacent structures. So those structures don't become deteriorated and also just cut down on the overall friction that is in that area. Another structure associated with it is going to be tendinous sheaths. Now, these sheaths are going all around the outside of the tendon. And because often muscles sit next to each other or on top of each other, we get a lot of friction and rubbing happening. Well, the tendons, which are how muscles attach to the bone, those tendinous sheaths are going to help protect those tendons so those don't deteriorate. So a lot of protection happens in the form of stability or reducing friction because so much movement is happening at the joints. The other stabilizing factor, this is sort of what I mentioned before when I talked about the shapes of the articulating surface. This is going to play a minor role, but still a role in how stable a joint may be. The ligament number and location, like I mentioned earlier, also going to play an important role on how stable a joint is. But the most important factor is going to be muscle tendons that cross that joint and the particular strength of that muscle. So all of these factors are what's going to stabilize any given joint. And again, the number, the location, and the strength is going to be different at each joint, giving the joint either greater ranges of motion or greater protection. So as far as the movements that happen at a synovial joint, we're going to start getting into muscles next. So it's important that we understand the connection points of muscles to bone. The first thing you need to understand, or the first rule, is that there is going to be an origin and an insertion point. An origination point is where a muscle originates from, and an insertion point is going to be the bone or the attachment point in which it inserts or attaches to. Now, the key thing about this is that the origination point is not the moving part. This is going to be the immovable bone. The insertion is the movable point. So when a muscle contracts, the insertion point typically is moving towards the origination point. So that's sort of the rule of thumb when we're looking at origination and insertion points of a muscle. The example here is the semitendinous muscle that we find inside the upper leg. The origination point is going to be on the ischial tuberosity of the pelvic bone. And so that ischial tuberosity comes off the ischium, or the posterior inferior part of the pelvic bone, and it's inserting down onto the proximal tibia, medial to the tibial tuberosity. So that's sort of the insertion point that we find there. And that is going to help move that muscle, or that insertion point is going to move towards the origination point. By understanding a muscle's origination and insertion point, we can then visualize that insertion moving towards the origination point, which allows us to understand what the action is of that muscle. When we look at movements of these joints or these segments, we are looking at those movements and they're going to go along those planes that we memorized. So the transverse, the frontal, and the sagittal planes. And so all movement of the body are moving about those planes that we've studied in the past. So here are the different movements that we have inside the body. So flexion and extension, and you could see these movements. I encourage you to practice these movements as you say them out loud. So doing flexion or forward flexion of the shoulder is this first picture that you see. The second picture would be extension or moving that arm backwards. And so that would be what we call extension of the shoulder. When we look at the knee in the first two pictures, we have flexion of the knee, and then we have extension of the knee. Okay. We also can do flexion and extension of the neck. And so bringing the chin to chest would be flexion, and extension would be the act of moving it backwards. We can look at the hip with flexion and extension. And then we have abduction and adduction. Now, the proper way to say this is abduction and adduction. Whenever I am teaching or talking about it, I often say abduction or adduction, just to clarify so that students can pick up what I'm saying, but the correct way to say it is abduction or adduction. We have circumduction, which is the rotation or movement of the arm in a circle, or the shoulder sort of in a circumduction or circular motion. And then we have medial and lateral rotation. We can also do that with our arm or our leg, our hip. So moving our leg laterally or in lateral rotation or in medial rotation. And of course, we can rotate our head, and that's the act of rotating our C1 on our C2 vertebrae would give us that rotation. Some other things is pronation and supination. Pronation and supination is just going to be the radial head rotating over the ulna. And I think of soup like holding a bowl of soup. So moving into supination is turning your hands to grab a bowl of soup, right? And pronation is going to be the opposite of that. We can also use these terms to describe how a patient is lying. By the way, we could say a patient is laying prone or the patient is laying supine. And supine and prone are the same things, in that they're laying face up would be supine and laying face down would be prone. Just so you know, those terms can be used elsewhere. But supination, the act of moving our palms in the face up direction, and pronation would be the act of moving our palms into the face down position. All right. We also have plantar and dorsiflexion. Plantar flexion would be moving the sole of the foot towards the ground. I think plants are in the ground, so moving your foot that way. And dorsiflexion would be moving our toes up. And then inversion and eversion. Inversion, the soles of the feet are pointing in. Eversion, we're everting or pointing the soles of the feet out. Our mandible, we can move with protraction or retraction. Protraction would be jutting the jaw out. The act of retraction would be pulling it backwards. And then we can elevate and depress the mandible. Elevate would be meaning coming from an open position to close. And depression would be opening the mandible or opening our mouth. And then there's the act of opposition, and that would be the ability to move our thumb and fingers together, right? So opposing. So we could do it with our thumb and our pinky. We could do it, with other digits, but moving them together would be the act of opposition. All right, so the types of synovial joints. So this you will need to memorize and make sure you understand what the joints are, the type of movements they are, and where we find them with inside of our body. So there are 6 basic types of synovial joints that we have, and it's based on the shape of the articulating surface. So how those two joints are going to move together, which is going to then give way to how those joints actually move and what they are doing with the segment, or how that segment can move. So we have plane type joints. That's our first one. If we look at the tarsal bones and some of the carpal bones, we have planar type joints. You can kind of see this movement here and how the planes it can move on. So kind of flat surfaces gliding, if you will, across each other. We have hinge type joints, and a hinge works just like a door has a hinge, right? And the elbow is a good example of this. And here is a hinge type joint. And you could see the articulating surfaces of these. A pivot joint, so between C1 and C2, which gives us the yes motion, or no, sorry, the no motion. So the act of rotation of our neck, of our C1 on C2. So if we look at the little dens that sits up on our C2, and the opening of the atlas, or the C1 on top of the axis, creates that rotation or that pivot, and that gives us the action of shaking our head no. A condylar joint or ellipsoid. When we look at this, a good example would be between the radius and the carpal bones, and you can sort of see the movement of that. The saddle joint is between the trapezium and the carpal bone. So when you go back and look and study the wrist, this joint, our thumb joint, is our saddle joint. Then the next one is the ball and socket. In the ball and socket, we have in places like our hip or inside of our shoulder. All right, so take some time to go back into these charts and make sure that you're studying them. Make sure you understand where we find these types of joints inside of our body. All right, let's look at some common injuries that we have within joints, and you will most certainly see patients with these. The first one is going to be a sprain. And so when we have a sprain, we have a ligament that is going to be stretched or torn. And depending on how torn it is, we would grade that as a grade 1, 2, or 3 ankle sprain. Partial tears are going to slowly repair, and that's typically because in places like our ankle, we don't have as much blood supply. So there's what we call poor vascularization. So ankle sprains can take a long time to heal. Also, not only the lack of blood supply, but when we look at ligaments themselves, within those ligaments, there's not a lot of blood supply to the ligaments. Now we see more inside the tendon because of the muscle attachment, but not so much inside of the ligaments. So they do take a long time to heal. If they are completely torn, some of the repair processes is that we can sew the ends together. We can use a graft and put it over it. And then also time and immobilizing that area so that it can heal is going to be important. This is just looking at the differences between an inversion, eversion sprain. And because it is overstretching these ligaments, that's going to dictate where we end up with the injury. So on an eversion, you see the lateral side of the foot is where we are going to see the injury, as opposed to an inversion sprain versus an eversion sprain. We see it on the medial side. So some other common injuries are going to be what we call dislocations or luxations, is another term for this. This picture shows a shoulder dislocation, which, as I mentioned earlier, tends to be one of the common dislocations that we have. And the bones are forced out of alignment in this. And this can happen because of sports, accidents. Usually this is going to be accompanied by sprains, because as those two articulating points are stretched or moved away from each other, the the ligaments that hold them together are often going to be stretched. So we do see that with them. So we'll see inflammation. And remember, when we think about tissue repair, which if we have an injury within the ligaments and possibly the tendons, we are going to see the repair response, which one of the first actions of repair is going to be inflammation. Because of the presence of the increased fluid, because the body's trying to repair itself, we often see difficulty moving. And if the joint is still out of place, like a shoulder often can be, we'll see difficulty moving not only because the increased amount of fluid, but the articulation spot no longer is articulating properly. And so we don't get the right movement. The other thing that can happen is that the muscles start to contract to help protect and stabilize the joint. And so it gets really tight, also going to contribute to the amount of pain. So if we think about the nerve supply that's going to be in this area because of the vast amount of musculature and the vast amount of information the body needs to pick up about the location of this joint, The excess fluid and the enzymes of repair that we often release are going to start irritating those nerves. And so this often is accompanied by a significant amount of pain. When we think about the amount of inflammation, for us to fully treat this, we are going to have to work on the inflammation and work past that. When we talk about, so that's a full dislocation, is a luxation. A subluxation is a partial dislocation of a joint. So some inflammatory and degenerative conditions. The first one here is bursitis. And we talked about the bursa sacs that we have around the body. And when we have inflammation, which the ending itis often signifies inflammation. So if you see that attached to a word, you can guess that it's going to be, if we see itis, that there's going to be inflammation. So this is just bursitis, which means there's inflammation of the bursa. And this usually is caused either by a full blow of an injury or a friction type response. This is usually treated with rest and ice. And if it's severe, we might give some anti-inflammatory drugs to help decrease the amount of inflammation in the area. The next one is tendinitis, and this is usually when those tendinous sheaths have too much friction. So this is an overuse type injury, and this is going to have similar symptoms in that there is going to be inflammation, possible, swelling with that, and it's going to cause some pain and lack of range of motion. Tendinitis, there are different types of tendinitis we can get. We can get lateral or medial tendinitis. These are usually just caused by overuse type injuries when we're talking about the elbow or other places inside of the body. So we can get bicep tendinitis, any really muscle that we are overusing and the tendon starts to become inflamed. This is what we would call it. Okay, arthritis. Now, arthritis is a big can of worms. There are a lot of different types of arthritis that are out there. There are over 100 of them that fall in the category of either inflammatory or degenerative types. This is the most widespread crippling disease. So without a doubt, you will treat patients that are suffering from arthritic changes within their body. The symptoms of it, or the clinical symptoms that a patient might present with, is going to be pain, stiffness, and swelling of the joint. There is going to be acute and chronic forms. Now remember, acute just means something that is immediate or a very recent type injury, and chronic is going to be long-term bouts of this. So acute is often caused by bacteria, can be treated with antibiotics. And then a more chronic form are going to be the ones that we really think of when we think of arthritis. So this is going to be things like OA or osteoarthritis, rheumatoid arthritis, or gouty arthritis. And so here in this, you can see a healthy joint. In this middle picture, we can see an osteoarthritic joint, and you can see that it's bone on bone. So part of this cartilage has disintegrated, and there's also no space for synovial fluid. And so the pain is coming from the fact that this patient is going to be bone on bone. Now, as these bones rub together, we'll also see arthritic changes within the long bones of themselves because of the destruction that's going to happen. In rheumatoid arthritis, we see bone erosion in other places because the entire bit of synovial fluid or that synovial capsule starts to become really inflamed and agitated. And so the entire joint capsule, we start to see arthritic changes, not just the bone on bone. And so it's not usually in those like hidden articulating spaces, but rather in other parts of the joint itself. So here's osteoarthritis. This is a very common one as we start to age. And so this is part of the normal aging process, part of wear and tear. But as you accumulate injuries while you're young and getting into adulthood, those injuries are typically the spots where we're going to see arthritic changes later on. And so if you've ever sprained your ankle, or you have other injuries, it is possible that you already feel this, like if the weather changes, or maybe in the morning, certain parts of your joints hurt a little bit if you've had significant injuries. And that typically is because you have arthritic changes. And when we say that, we're saying that you have osteoarthritic changes. So more cartilage is destroyed than replaced, and then the joints are badly aligned, which, like I mentioned a minute ago, those bones start to sort of fragment and disintegrate. The treatment is moderate activity and then mild pain relievers. And then there can be topicals that we use that help. So things like capsaicin creams we might prescribe a patient. Here is a picture of someone with rheumatoid arthritis. So rheumatoid arthritis is chronic inflammatory autoimmune disease. Autoimmune meaning that the body's immune response is overreacting and starting to attack itself. And so those cells are attacking the joints in someone who has rheumatoid arthritis. One way to know the difference between rheumatoid arthritis and, let's say, osteoarthritis is going to be either unilateral or bilateral. Often, and more times than not, rheumatoid arthritis we will see bilaterally because it's systemic, meaning that it's not just one side of the body or the other. Oftentimes, osteoarthritis, we see it more pronounced or in just one side of the body. Now, that doesn't mean that both knees can't be arthritic and it still be osteoarthritis. Just sometimes a good sign would be whether or not it is bilateral or unilateral. Bilateral meaning both right and left sides, unilateral meaning one side. So rheumatoid arthritis we'll see on both sides because it is a systemic response or an autoimmune response. What happens here is synovial fluid is starting to accumulate because of this overactive immune response to the joints, and we're finding those cells in there. We're detecting our cells as non-self, even though they are, and so the body goes in there to try to repair and fix it. Well, it overreacts in that way, and so we start seeing synovial fluid starting to accumulate, and it's going to start to swell, and then synovial membrane itself becomes thickened and we get a buildup of irregular articulating cartilage. Now, what happens is that we start seeing that cartilage erode and scar tissue starts to form. And anytime we have scar tissue inside of our body and we're repairing, while we're good at repairing ourselves, we don't do a super grade A job at it, in that the tissues that we put down, that scar tissue, never acts or responds the same way the original tissue does. And so the ends of these bones, of the articulating bones where that scar tissue is, we call this ankylosis. I was going to say something else with that. Don't know where I was going with this, but ankylosis is the term we get for that. Signs and symptoms, joint pain, swelling, anemia, because we're seeing differences or changes within the blood because of the immune response, osteoporosis, we often see muscle weakness, and then cardiovascular problems. We often treat with steroidal and non-steroidal anti-inflammatory drugs, and then of course immune suppressant type drugs might be prescribed because of this autoimmune involvement. The last one was gouty arthritis. This is because of buildup of uric acid crystals, and soft tissues. And so you could see that here. We call this tophi, and these are the little uric acid crystals building up. And the buildup within inside of these joints, where these joints should be clean and articulating, we see buildup of that. And our body's response is to become inflamed and swollen, which then is painful. Usually, or one of the main places we really see this, although we could see in other joints, are going to be in the big toe. If we leave this untreated and we have constant flare-ups of gout, we are going to see the ends of those bones start to fuse and the joint sort of becomes immobile and it can't function the way that it needs to. So the treatment, there are different drugs we can treat with. Water is going to be important, the avoidance of alcohol, and also red meats would make this list. So basically anti-inflammatory diet is going to be needed for this. We often see this more prevalent in white males just because of their physiology and the breakdown of some of the products inside alcohol and inside red meats.
I hope that coverage of Chapter 9 helped you understand joints a little bit more. Using things like flowcharts or mind maps might be a great way to organize the different types of joints and what joints within our body fall into what categories. Happy study!